Good afternoon. Welcome to today's Grand Rounds presentation. Please remember to fill out the attendance record at the back of the auditorium, and also please remember to fill out the program evaluation. And I will again ask you to give us any ideas that you might have in regards to future topics and future speakers. It's my pleasure today to introduce Dr. Larry Otteman. Dr. Otteman is board certified in internal medicine and Hematology, Oncology, but more germane to today's discussion, he's also certified in hospice and palliative medicine. He is the co-director of the Homeward Hospice Care, and he's here today to discuss ethics at the end of life. Please join me in welcoming Dr. Otteman.
Let's make sure I have that on. There we go. Is that on? Here we go. Thank you, everyone, for coming in. It's a good thing we hold these talks inside. The crowd would be considerably smaller if we were outside. I wanted to visit today with the group with several purposes in mind. Maybe the most practical is that for the providers in the group and for those who will be looking at the YouTube, this does fulfill a state of Iowa requirement for one of the 2 hours of end-of-life medical education, so that's a practical point. I also wanted to just highlight the fact that we do have the hospice program, which everyone knows about, has been present since 1985 when the Medicare law was passed. But we also have an ongoing and active palliative care service. Joni Williams is our current representative, and she's doing a great job. The object of today's meeting is to understand a couple of things. I was an ethics major in college, and one of the things that was eye-opening is that in a situation where there was a difficult decision to be made, that you could actually sit down and sort of reason through what might be good reasons, what might be bad reasons, or unacceptable reasons for the actions that you would take. And so I want to introduce a couple of concepts to you pertaining to two issues. One, not so common, which is palliative sedation, and the other is the difference between killing and allowing to die. This is a table that comes from the ethics group at the Mayo Clinic, and I'm going to not talk about physician-assisted suicide, nor am I going to talk about euthanasia, both of which the intention of the intervention is to end the patient's life. Of course, this isn't entirely no for a physician-assisted suicide. There are a few states and the Supreme Court of Montana which have allowed that. I do want to talk about these categories. First of all, sedation, and then secondly, both withholding and withdrawing disease, which are very similar from an ethical standpoint. I want to begin with a vignette. I think this is always helpful, and I want you to take seriously how you would manage this woman's request. She's 62. She's been a smoker. She's dying in her home with the help of hospice. She is comfortable from the standpoint of pain and being short of breath. But she visits with you as the hospice physician, and she is in constant psychological and spiritual distress at the thought of her impending death. And in her own words, "I know I'm going to die. I just can't tolerate lying here thinking about it day after day." And she asks that she be sedated to the point of unconsciousness until the time of her death. This is a vignette that was mailed a few years ago to over 2,000 internists, adult medicine, and family practitioners. And the summary of that mailing was the following, that 21% felt that this was either very or somewhat appropriate, and 72% thought that it was not very or not at all appropriate. Another question that was asked as part of this was if any physicians had sedated a patient to the point of unconsciousness until the time of death, and only a small percentage had, about 10%. And I don't know how you answered that in your own mind, but that might give you a sense of where you would fit into this large survey. The next thing I'd like you to do is they broke down the idea of palliative sedation to get more information, and I'd like to have you think seriously again about these questions and answer in your own mind how you would answer the questions. That this statement, unconsciousness, is an acceptable side effect of palliative sedation, but it should not be directly intended. And we'll talk a little bit about the history of that wording. Doctors should sometimes treat the spiritual suffering of terminally ill patients. That was the case of the woman in this vignette, by sedating them to the point of unconsciousness. The statement that each person has the right to decide whether or not to hasten the end of his or her life, and then sometimes intentionally hastening a patient's death is the right thing for a doctor to do. So think about how you would answer those. They don't have to all be yes or no, obviously. There may be things about those particular scenarios or situations where you would answer one yes and one no. I'm going to show you the answers from the over 2,000 providers that were in that survey. So the notion that unconsciousness is an acceptable side effect but should not be directly intended was actually widely supported, and it's supported in the ethical and in the field of medical ethics as well. The idea that patients should be treated to the point of unconsciousness with sedation for spiritual suffering, again, only a minority, and a similar number to people who would have sedated this woman in the vignette. The recognition that every person has the right to decide is 69%, and then interestingly, sometimes intentionally hastening a patient's death is the right thing for a doctor to do, which is a pretty radical statement because it's not qualified by the means for hastening the patient's death. But a substantial minority, 42%, would actually support that statement. Lots of qualifiers, what would be the situation. But to give you a sense of where American medicine, at least at the provider level, is right now, those are the sorts of answers in the survey. I want to go many, many centuries back to a theologian and philosopher, St. Thomas Aquinas, who wrote in his master work a description of what's been known since that time as the principle of double effect. I'd like to show how that principle is applied then to the ideas of palliative sedation. Again, it's a way of thinking through this to determine, could you agree or not agree? The wording is medieval, as you'd expect from St. Thomas Aquinas. The permissibility of self-defense to the point of killing another is the issue that he was dealing with. So if the interdiction is thou shalt not kill, but there's a human realization that self-defense is acceptable, people wanted to know how could those two principles be rectified. So it was in the discussion of self-defense that this principle was first enunciated by St. Thomas Aquinas. Nothing that hinders one act from having two effects. That is, two things can happen from a single action, and only one of those can be intended, and that's the underpinnings of double effect. This is from much more recently, those of us in medicine don't think of 1949 as recent, but in the humanities, that's right up to date. And so Joseph Mangan restated the principle in this, and then I'll restate it yet again in a even more recent reiteration. I'll let you kind of read through that. And these are the 4 things that have to be in place for the doctrine of double effect to be used. The action itself is the object, and that is that it's good that you try to do this thing, or at least it's not bad, that the good effect and not the evil effect is intended, that the good effect is not produced by the means. So if the object is to end a patient's life, that's a bad effect. That's not a good effect. And so that's where this comes in play. And that there's a proportionate difference. It's one thing to sedate a terminally ill patient to the point of unconsciousness, perhaps. You might have a much more difficult time justifying that for a 16-year-old teenager who feels that her world is ended with the falling apart of her most recent alliance with the quarterback for the team. So their situations are different. This is sort of the most modern restating, that there is something about the nature of the act that has to be taken into account. The act must be good, or at least morally neutral. There's something about agent intention, and that's usually where people have the most trouble with the principle of double effect, but that the agent intends only the good effect, even though the agent may understand that there could be a bad effect. That there is a distinction between means and ends, or means and effects, that the bad effect must not be a means to the good effect. And then there's this issue of proportionality, and that's generally the other point of discussion about the principle of double effect, is whether there's anything that would justify someone's death. Now, these are examples. This is not an ethical principle that was devised only for medical ethics, but in fact, it's been used in a wide variety of situations. During World War II, it was used widely to justify tactical bombing with unintended civil casualties. The relief of suffering with the unintended effect of hastening death, and that's what we're talking about today. There's sort of this weird thought experiment, which is referred to most often as the runaway trolley, with 2 tracks, and I'll talk to you about that in just a second. And then there's also a discussion during the war about a soldier who throws himself on a grenade and ends his life, knowing that he will end his life, and how the Catholic Church should interpret that action and the death of that soldier, and whether it was suicide, which is prohibited. And so the principle of double effect was widely utilized to reassure families that that wasn't a suicide, and that the soldier could go to heaven. Now, this is the trolley with 2 tracks illustration, and it's pretty straightforward. There's not a third answer, so there are only 2 tracks, and so the point is that the handle is pulled this direction. That means that this trolley, which can't be stopped, is going to go down this track and kill these 5 people. And the choice that the agent has is to push the handle all the way forward, which will divert the trolley down this track, which will kill this single individual. And not that there's ever been an actual case of this, but it's an example of what oftentimes takes place in philosophy and in ethics in particular, which is to try to tease out the elements by making up a scenario and trying to understand, what's intended, what's not intended. And so that's a common illustration of the principle of double effect. And you can decide for yourself whether you would not touch the handle and would allow the 5 to be killed. There's a large body that would defend that, saying, you know, I didn't set the odds. I didn't set the game up, and I don't want to play in the game. And there are others who would say you're morally obligated to divert the trolley. And there's no right or wrong answer. This is one of the beauties of philosophy and ethics, is that you can argue both points. I want to talk a little bit about this topic of palliative sedation. Lots of different names for this. It's the name that I've become most comfortable with, but you can certainly find other terms. There are probably about 30 different terms. The side effect of hastening death is an inevitable result of the administration of opioid drugs. That's the underlying presumption, and this is actually referred to in one of the Supreme Court cases having to do with Nancy Cruzon. So that's a given. Now, we'll talk about that a little bit, but that's sort of a given for the point of discussion. And that hastening death is not an unwelcome side effect if in the providing of pain relief in the context of a person who's terminally ill. Their life is very short, regardless of whether you provide this sedation or not. And it's understood that it's not permissible to intend to kill the patient to end their suffering. But that if the first is true, that giving opioids will hasten their death, that is an unintended consequence. This is where the principle of double effect comes in. Well, not surprisingly, people have taken that whole thing apart, but one of the things that one can question about this whole example, even though it's quoted very frequently, again, even at the level of the Supreme Court, is that in a very large number of patients in a hospice setting who were terminally ill, only some of who received sedation to the point of unconsciousness, others who did not. Statistically, there was really no difference in the survival of the group. So the very assumption that you're going to hasten someone's death with palliative sedation is really been called into question. But out of interest, with this very large number of patients, we can learn a little bit about the practice. So there were 43% who were sedated, and the most common indications were not necessarily pain. Actually, that's been my experience and almost everyone's experience in hospice, is that pain is usually not the thing that's the most difficult to control. It may be delirium, it could be psychological distress, spiritual distress, or it may be dyspnea, shortness of breath. And in the talk I give to hospice volunteers, dyspnea is a symptom that is, I think, both more terrifying and more difficult to control than pain is. And then the most commonly used medication is to use benzodiazepines for palliative sedation. In fact, as a side point, one of the things that we learn in hospice is that morphine is a terrible drug to sedate patients. We quickly become tolerant to narcotics. And whether you're getting 1 milligram an hour or 1,000 milligrams an hour, you may still be wide awake. If you've only got a few morphine receptors and they're already occupied, the rest of the morphine that you give isn't going to make you more sleepy. So it's, even though the illustration is about giving opiates and terminal or palliative sedation and hastening death, the truth is that you can't really do that with narcotics in a person that's been exposed to narcotics already. There's a distinction that's been made by Dr. Timothy Quill, a very good writer, a good thinker in the field of hospice and palliative care. And he, in an influential paper in the Annals, wanted to distinguish between the different kinds of sedation. So there's ordinary sedation. It's the person who's anxious or nervous and they ask for some lorazepam or for some diazepam to handle the anxiety of the moment. You don't want them to be overly sedated or unconscious. We do that all the time in the office. There are patients who require more sedation, and the goal here is to relieve whatever level of anxiety they have, but you're not really trying to make them unconscious. You simply want to alleviate the anxiety that they have. And then there's the palliative sedation to the point of unconsciousness, which is an unwieldy phrase, I will agree, but one which I think captures what the intention is. To relieve suffering, and the goal of it is to render the patient unconscious. In the field of hospice medicine and palliative care, while not everyone can agree on all of the principles, there is fairly wide agreement in terms of what should be in place if one were to consider palliative sedation. And you can read these. It's agreed that someone should be terminally ill, that their symptoms have not been able to be managed, that they have a do not resuscitate order, and in effect that all other efforts with various palliative treatments have simply not been effective or aren't applicable. A consideration for whether consultation, not with medical specialists, but with other members of the palliative care team, for spiritual assistance, ethical assistance with the ethics committee, and a psychiatric consultation if it appears the patient is depressed as the primary motivator for this. And then a good discussion about whether it makes any sense to maintain artificial hydration or nutrition while someone is purposely rendered unconscious. And then finally, that the patient should be able to give their consent to this procedure. Always the sort of safety net that we depend upon. Oops. A couple more practical points. These I don't think repeat too much, and that is that it's not very common that you do palliative sedation. I have, and as a palliative care physician, I'd be happy to consult if that's something that people are considering. But the feeling is in the field that if you have access to a palliative care specialist, this might be one of those sort of special things that palliative care physicians do. It's important that everyone in the staff at least have a chance to weigh in on things, or at least understand. There's a lot of room for misunderstanding with something like palliative sedation, and unless the nursing staff and other providers are part of that, they can misunderstand the intention. And the most important distinction is that there is a difference between rendering someone unconscious with palliative sedation and euthanizing them. That is, actually intending to end their life through a direct action. Again, getting the consent, it's important for the nurses who are always left to carry out these orders that you be at least as specific as you can be. Writing an order like begin palliative sedation is worthless. And so you have to be as specific about this as you would be about giving somebody Levofed or a dopamine drip or anything else that you do by infusion. This is something that needs to be documented like any other treatment and treatment discussion. And one of the recommendations is this doesn't happen very often. You might make a conscious effort to discuss it after the event. So that's everything that I'm going to say about palliative sedation. I'm going to move on, and then I'll be more than happy to answer questions. I wanted to visit about a separate issue. I mean, obviously they're both having to do with the end of life, But this in particular has to do with the distinction between killing and allowing to die. And there's a very renowned ethicist, Daniel Callahan, who I think has written clearly about this, and I'd like to share some of his thoughts. So, knowing as pulling the plug. What are the ethics of pulling the plug? Another vignette. There's not a right or wrong to this, and so I wanted you just to get a flavor for things. I think the vignette does a nice job of capturing what we all experience, and that is these decisions are made one at a time with the best of intentions, and you can always step back and say, how did we get here? 6 or 8 weeks down the road when someone's on a feeding tube, but it happens all the time. So a healthy 55-year-old construction worker came in just for an elective cholecystectomy and arrested during surgery. He was ventilator dependent after 3 days, not brain dead, and the decision was to support him, not knowing exactly what was going to happen. And his family was spoken to. They're very loving. They're very supportive. All the providers were on board with that. After 2 weeks of this, it became as apparent as can be that he was actually likely to exist in a persistent vegetative state. We can talk about the neurologist's role in determining that, but let's take it for granted that that diagnosis was made. And it was decided by the family, knowing what his wishes had been, that he would not want to be kept alive artificially on a ventilator. But as happened in Karen Quinlan's case, when the family made the courageous and finally court-supported decision to take her off the ventilator, this gentleman continued to live, which supported the persistent vegetative state. At that point then, people said, wow, maybe we need to give him some more time. They continued with the feedings, and then finally, after 6 weeks, the family decided to withdraw the feedings as well. Somewhat like the decisions made in the Terry Schiavo case. And he went on then to die not very long after that. And so this picture, as opposed to the other one I showed you, which shows a loving family saying goodbye, being supportive in this gentleman, is more the picture that we'd like to keep. This is an analysis that I wanted to share because I think it does help to explain how did we get to this point where people would assume that pulling the plug, taking the man off the ventilator, was killing him. And so Callahan steps back and says, well, let's think about medicine and doctors and their interaction with people. For centuries, and until the last 100 years perhaps, in all that time, there was really never a choice that a provider had about whether he was going to let someone live or die. That wasn't even a sensical statement to make. And so everyone agreed that you couldn't kill someone, but the notion of, am I responsible for them living or dying didn't make any sense medically. But as we're all aware, and we're all grown up in this era, there quickly became lots of examples of life-extending treatment with mechanical ventilation, cardiac care units, parenteral nutrition. And so there was a technological ought, if you will, and that is that doctors ought to provide such treatment. It kept people with bad burns alive. It kept surgical patients with wound dehiscence alive. So, this was something you could do, and you should do it. From this ought, that doctors ought to provide this treatment, it was easy to conclude that failing to provide such a treatment was morally wrong. If that's what they ought to be doing, then if they don't do what they ought, then they're morally wrong. And it was still understood that the patient was dying of the underlying disease, but it became this sort of mandate that if you can do something, you should do something, and you're morally wrong if you don't. Now, that's kind of medicine in the 40s and 50s, if you will. At the same time, there was a body of legal doctrine that was being worked out in the United States, and it, based on Catholic teachings, made distinctions about what was futile treatment or unduly burdensome treatment or a treatment rejected by the patient. And up to the Supreme Court, there was a recognition that there was a right, legal and moral, for a competent person to refuse treatment, that this right then extended to incompetent dying patients, and that it was morally acceptable to use pain medication despite the risk of hastening the patient's death. That's the phrase that was used in the Nancy Cruzon decision. So there was the feeling that there may be a difference then between allowing to die and killing the patient, and that difference was who the primary mover is. The disease remains the cause of the patient's death and not the cessation of treatment. And that's where the field is right now, trying to step away from the technological imperative of medicine, which is if you can do something, you should do something, and you're morally wrong if you don't, to recognize that not doing something is not what causes the patient's death. And that this obligation to treat was never a scientific fact. It was sort of a societal decision that said, all things considered, we should support physicians who aggressively support life. A wholeheartedly great principle. But the idea is that as a society and as a moral society, we could make these rules and say, this is how doctors should behave. But that we make an error when we say that not being able to stop a lethal disease and stopping treatment because of that is the same morally as causing the death itself. That that's not an accurate moral or logical statement in the field of ethics. So not being able to stop a lethal disease and stopping treatment are not the same. This isn't just Dr. Callahan's thoughts, obviously, but there is a large body of literature and ethics manuals. The American College of Physicians, a fairly conservative and respected body, agree that either withholding or withdrawing treatment is equivalent. There's no difference between starting and stopping. It may seem that way, but ethically, morally, and legally, it is not. And they felt that it was important that treatments not be withheld because of the fear that once something is started in a patient's care, that it can't be withdrawn. And that's not an uncommon thought even today. But the American College of Physicians says that's not the case. Withdrawing and not starting something and withdrawing a treatment are the same. This is the AAHPM, is the American Association of Hospice and Palliative Care Medicine providers, that not only ventilators, but things like artificial nutrition and artificial hydration are to be thought of as interventions, and things that can be thought of as a conscious decision to start and to stop. That initiation or continuation should be evaluated by the benefits and burdens of the intervention, none of these sound like radical concepts, but they're important in discussions with families and providers. And like all interventions, these can be ethically withheld or withdrawn, consistent with the patient's wishes in the particular clinical situation. So a statement from a recognized group of providers who actually face these decisions on a day-to-day basis. A lot of this dates back to a commission in 1983. That's quite a while ago now, 40 years. 30 years. We'll do the math. That a competent, informed patient may choose whether life-sustaining therapy is undertaken, that providers should maintain the presumption to sustain life, but recognize this patient right, and that a treatment is only warranted with this balancing of benefit and burden. And then finally, the fact that someone doesn't have capacity to state their wishes should not somehow punish them with treatments that most people would think of as onerous, and that is lack of capacity does not deprive a patient of the same rights as long as there are surrogate decision makers which are appropriate. So we're going to go back just to summarize. We didn't talk about physician-assisted suicide or euthanasia. We talked about palliative sedation for the relief of symptoms. It is legal to do so and morally justifiable in some situations. This distinction between withholding and withdrawing, although it seems to be a difference between putting someone on the ventilator and taking them off the ventilator, they are, in fact, in all of the major American groups, equivalent actions. That in this situation, the most important thing is to realize that it is the disease that's ending the patient's life and not the actions that you're taking or stopping. And that the burden of that intervention is really the key point. And these, again, are legal and ethical and moral. That's everything I wanted to say about the topic. We still have 14 minutes. Emily's got the microphone. And I'd be glad to answer questions, thoughts, comments. We'll go from there. Yeah, Nick.
Might be a silly question, but most of what you presented had the background of the Christian thought and probably more the Catholic thought.
Yeah.
So now in an America or this society that has more diversity, so where are the other thoughts? The atheist, the Muslim, the Protestant?
Yeah, it's a very good question. The question is, I've presented, I think, fairly, as a commentary and probably even a criticism, is I've presented a Judeo-Christian point of view, if you will. I think that the Jewish community, as I understand it, would largely support these distinctions. I'm not as well versed in the other religions. The Pew, can't think of the name of it, but it's the company that does, or the foundation that does the polling of different groups, put together kind of a summary of what various faith groups and religious groups hold. In their summary, that the idea that someone could refuse a treatment that was burdensome is fairly widely held. I don't think anything's universal, but I'd say that notion that we all have a right to say, I've had enough, I don't want anything more done to my body, is pretty close to a universal value. And I think that's important to recognize because that's a very important underlying principle anytime that we start talking about limitation of treatments and so on, Nick. There's no question that there are some religious traditions, even within major groups, that would say that anything other than a full-out effort to support and maintain life in any form is wrong. And the truth is that we have all of us witnessed a form of that, at least in two world figures. One is Nelson Mandela, who, as everyone knows, went home on a ventilator and died at home. Maybe people didn't realize that, but he went home on a ventilator. And then more recently, Ariel Sharon, who died a long time after, I think it was a stroke was the initial event, and had extraordinary efforts at preserving life. And I don't know that those are necessarily a representation of a religious tradition, as that may be the burden you carry if you're world famous. Nobody wants to, no doctor wants to be the one that says, yeah, I'm the guy that let Nelson Mandela die. So, that. But it's a very good point, Nick. Other questions or comments?
Following up on that,
Yeah, Louis?
would you comment or make a few words regarding the conflict that may occur when the family's view and the wishes may conflict with the physician's personal beliefs about end of life?
You bet. And that's, there can be conflicts between the physician, the providers, and the family. There can be conflicts, obviously, within the family. Not everybody's going to be on the same page with the same decisions. I think, in general, you can state as certainly as anything that you can say about a decision in medicine, and that is that the person who is involved, the patient, has the right to stop any treatment that they want. And if you can figure out what that person wanted, that trumps. And that's not uncommon. I've had occasion, just as an anecdote, of a very bright gentleman who made it very clear, and he was certainly competent, that he just didn't want to stay in the hospital. He didn't want to continue on supportive therapy. He wanted to go home and die. And his son, a 5-time Iraqi and Afghan Marine, said, no, we're not going to quit. And, I sort of said to the son, you don't get to decide that. Your dad does. And your father has told us what his wishes are. And like a good soldier, he accepted that. So, I think that there's always going to be conflict, and the problem, of course, arises when no one's really made their wishes known, which is a great plug for making your wishes known so your family's not in this situation. Next question.
Yeah, I was just wondering if, in reality, patient socioeconomic status has a role in how these things play out.
I mean, I think it's something that we should always be mindful of. I'm not, are you presuming that poor people would not be receive the same level of support as someone who's wealthy?
Yeah, I'm just wondering about that. Poor, or maybe like ethnic, racial differences.
Yeah, I think there may be more ethnic and racial. I think there's lots of good medical sociology that demonstrates that people that are not of the minority, or the majority rather, African Americans, Hispanics, feel as a group, not individually, but as a group, that they can't trust their white providers. There's an automatic presumption that they don't have your best interest in mind. So that's well documented. I think it has to be recognized, and it can make it very difficult when you're talking to a family if there is a racial difference and there's that sort of presumption that I couldn't be trusted because I'm a white male. I don't know if I've read anything that says specifically people make decisions necessarily on an economic basis. No, I can't answer that. Question?
I'm wondering, you made it very important, and I think it is, for letting your family know your exact wishes. But as we all know, there are so many nuances. So it's hard to say, well, if this happens and this happened, you know.
Sure.
So is there any like website or guideline or something that you could fill out so you could give that to your children?
There is, in fact, such a thing. So, there are lots of things, Linda, and I'm very pleased that you brought that up as a question. The McFarland Clinic, I'm proud to say, for over 20 years has had what I think is one of the best advanced directives in the country. And I mean that seriously. It is based on a model from the Ezekiels when they were working at Harvard, and it tries to have you imagine various scenarios with lots of different interventions. It's almost a worksheet. And so the McFarland Clinic Advanced Directive is just such a thing. There's also, for people who are terminally ill or at the point where they're seriously ill, the newest document, if you will, is called the IPOST, which is the Iowa Physicians' Orders for Sustaining Treatment. Scope of treatment, thank you. Cindy's my expert here. So that what we're trying to do now is to have people that are in the hospital have a discussion and say, if I go back to the nursing home, I don't want to come back. If I have a fever, I don't want to come back. So we are trying to not only talk to people about it, but to put documents in their hands. The other thing, of course, is to name someone as your medical power of attorney, because you're absolutely right. It's impossible to name every possible situation. And then you have to trust that the person that you name can be trusted to do what you would do. But there are things that can be done. Next question. Good. We've got a few minutes, so thank you very much. Appreciate it.